Hello, everyone. So just making sure that we are in the right room. So we are going to discuss about neuroscience-informed psychoeducation for both prevention and treatment of substance use disorder. And we have a panel of colleagues here. Dr. Vasilieva is going to be my chair, Jasmine, and with a group of speakers here. Mark was not able to make it, but hopefully we'll be able to entertain you for the next 90 minutes and discussing about how to use neuroscience for interaction with people and also communities. So the talk is being organized to start from the idea of brain rehabilitation and using neuroscience-informed psychoeducation for brain rehabilitation. Then we go to some kind of new trials that we have been doing, discussing about prevention, talking about communities, and then concluding. So that is the overview of the plan. But before starting the talk, what do we mean by neuroscience-informed psychoeducation, or NIPE? So that is the first question that we want to address and then move forward. So I'm based in the University of Minnesota. In University of Minnesota, we have one of the kind of first imaging centers around the world that started doing fMRI and all those kind of brain circuit analysis. And we have the largest brain scanner, 10.5 MRI scanner, 10.5 Tesla scanner. So it's the largest one in the world. And also kind of a group of people who are working on developing treatments using neuroscience. We call it medical discovery team on addiction. And my own lab is mainly focused to develop new technologies using neuroscience and brain imaging and brain stimulation to be able to target those neurocircuits. But meanwhile, as a clinician, when you are running these trials, when you are seeing patients, there is always a discussion in terms of how you can communicate about brain and neuroscience and recovery with your patients. What is the language, how you are going to do that? Those who are in the room, how many of you are actually seeing patients? Okay, so some like half of the people in the room, you are seeing patients. And Nora Volkov in the panel before, she was discussing about addiction as a brain disease, right? How much do we discuss with our patients about brain and addiction and how that is informing our clinical practice? We don't have a really good sound isolation from the room in the back, right? So, okay, good. So they probably can hear us as well, so we can just talk louder. So, okay, so the idea of clinicians and being a clinician and communicating that with the patient, we consider neuroscience-informed psychoeducation as a way to be able to communicate with our patients about neurobiological mechanisms that are involved in the disease of addiction in a way that it would be helpful for their decision-making, treatment selection, and their recovery, okay? And there are alternative terms for that. Instead of NIPES, there are people who say brain talks, neuroeducation, brain literacy, or things like metacognitive awareness, metacognitive education in terms of giving people cognition over their cognition. But starting from the first talk, and my colleagues are going to talk about that. So Tara is going to discuss about some of the NIPE standalone interventions that we developed. Arash is going to discuss about what we are doing for NIPE in communities. And Jasmine is going to talk about kind of prevention and also some harm reduction kind of interventions that we are doing. So I do not have any conflict of interest. My slides are in the QR code. So if you are interested to have my slides, you can scan my QR code. And then at the end of the session, I will also provide the QR code for the slides. So you can have access to my slides. But starting with the idea of brain addiction as a brain disease, we published a sort of textbook on neuroscience for addiction medicine and how neuroscience could actually be used in the clinical practice of addiction medicine, addiction psychiatry. The first edition was published in 2016. The second edition is going to be out in 2026. And it has some like 38 chapters, 800 pages. So there are lots of ideas how we can use that. But the question is how that is actually being used in the clinical practice in communication with the patient. One of the areas that we have always been interested was what we call neuropsychological rehabilitation or neurocognitive rehabilitation or cognitive rehabilitation for those brain functions that are being impacted by substance use disorder. And there is a textbook on that. It's called Neuropsychological Rehabilitation. Interestingly, for a long period of time, this book didn't have any chapter on psychiatry. We have been the first group that we added a chapter to that textbook about neuropsychological rehabilitation in psychiatry, and then expanded that to specifically in the field of addiction and the idea of doing brain rehabilitation for addiction. The first package that we developed, we called it Brain Gym. And I already have copies of Brain Gym here, so I'm going to give you the copy if you want to take a look inside to see how does it look like in terms of the structure and the way it works. So that was the first package that we developed, and it is a structure to have 16 sessions of brain training and brain games and engaging people in that process. When we have been developing that, we realized that we need to have some sort of knife elements there to be able to communicate with patients about their attention, about their memory, about the speed of their brain processing, decision-making, emotions, sleep, how they kind of enjoy life, kind of different brain exercises. We realized that we need to develop some modules to be able to communicate that with patients when we are doing brain rehabilitation interactions. And that was the starting point to develop some knife materials as a part of our Brain Gym package. This is the kind of the protocol of that package. We called it initially as NCORIDA, Neurocognitive Rehabilitation for Diseases of Addiction. And we started a trial in a series of residential programs and kind of using the brain training exercises. And the trial is now published. So it's a reasonably sized trial. So we had 120 participants divided in two groups, one active kind of intervention, the cognitive rehabilitation group, and also a kind of active control intervention, just a basic education, not the cognitive rehabilitation part. They have been opioid user. More than 50% of them, they also had comorbid methamphetamine and stimulant use disorder as well. In that context, we show that, okay, over the time, in 8 weeks of intervention, 2 sessions per week for 2 months, basically we can see improvement on some of the cognitive functions. It was more obvious on learning, things like working memory, and also marginally significant in some other areas like executive functions, kind of task switching, information processing speed. And this is the structure of the trial. So we had people in a residential program for 8 weeks. That was the initial step of the study. And then we had 2 phases of follow-up, a 3 months follow-up that had some further support with the trial, and also 6 months without that sort of extra support. So in the first 3 months of follow-up, we lost something like 50% of our patients, as you can imagine. It's hard to follow them. It was just complex to kind of find them in different places. And then in another 3 months of follow-up, we lost something like 80% of the patients. So it was not what we have been kind of looking for, but that was the reality of the clinical work. But interestingly enough, we showed that in kind of these moments, on those people who have been able to be kind of assessed, we showed that there is a significant improvement in terms of the level of consumption that they had. So both with opioid and stimulant use, we showed that there is a kind of significant lower level of positive urine drug test on those who have been assessed. Also, we showed that we have been looking into predictors of response. 2 major predictors that we showed. First of all, it was just those who received cognitive rehabilitation, they responded, of course, better, and also some baseline executive functions. Especially, we showed that things like in the Stroop task, we have a specific measure, it's called color word interference score. And it is when you basically read red here or read the color. So the time difference between that sort of Stroop interference. And the longer the time is the lower level of inhibitory function that you have. And we showed that the specific function was a predictor of retention in the program and also in the follow-up for the patient that we had. So that was the first trial. So we started to realize that the treatment context and the initial motivation of our patients and the services that we have been providing along with that sort of cognitive rehabilitation was very important in terms of the delivery of that cognitive rehabilitation. And we had a fantastic group of people who have been working with us, a group of kind of physicians. And I mean, we have been working as a group together. And that was a kind of very successful experience in terms of being able to deliver to the patients. And we received lots of really positive feedbacks from our clients or our patients. They have been very happy about kind of and they had other programs during the residential kind of stay, but they most of the time they have been preferring to join the classes that we had because we had fun, it was games, some kind of interaction, some competition in the classes. So people really enjoyed doing that. So it was a sort of motivation for us and thinking about how we can develop what we call Brain Gym 2.0. So we started to think about how we can kind of extend the idea and improve the model that we had. And we have been looking into different models. And in the first trial, the Brain Gym 1 was mainly focused on the cold cognitive functions, attention, memory, things like that. But we decided to basically add more sort of hot cognitive function, positive valence, negative valence, the areas that here we have as blue and red, emotion, reward. So we have been trying to see how we can integrate them to the package that we have. So we started to develop a new model and try to add those sort of different levels of hot and cold cognitive functions together and integrated them in 10 different modules. And we started to develop some cartoons for them. And why cartoons? As you can imagine, I mean, cartoons can be a media for interaction with our patients. They have been attention grabbers, memory-friendly medium, tools to reframe for patients, heuristic tools to inform their decision-making, and also a tool for developing self-awareness. Those who are interested, we actually published a specific paper discussing about cartoons in the context of neuroscience-informed psychoeducation for addiction, and the material is already available on the QR code. You can see that. So in the process of developing those cartoons, we started with multiple different drafts and asking our patient, which one do you relate more to? Or which one do you like to see in the cartoons? Which one do you like more? Character 1, 2, or 3? Who likes character 1 to be on the cartoons? Okay, few people. Who likes character 2 to be in the cartoons? Okay, few others. Who likes character 3 to be in the cartoons? Okay, more votes for character 3. Okay, so we have been asking people, which one do you relate more? Or here, character 1, character 2, character 3. Which one? And this new trial, we basically developed it for women in recovery. So we have been planning to run that in a center that was women only. So that was most of these characters are women characters. So from these characters, which one do you like more? Who likes to have character 1 as the main characters of the cartoons that we are developing? Character 1? Okay, few people. Who likes character 2? Okay, few others. Character 3? Okay, good. So we received the best response, and we had been working in a sort of diverse community center, and it was alternative to prison or alternative to jail program in the state of Oklahoma when we have been developing the program. And we received more positive responses towards character 2 because it was not really white, not really black. So it was sort of, to some extent, kind of race neutral, and people liked that. So, and we tried to optimize that sort of character. We went through different kind of sketches, tried to optimize that, and we ended up with this kind of series of cartoon with that specific character to be added to that sort of package. But in that process of developing those cartoons, we started to realize even some interesting nuances in developing those things. So one of the cartoons that we have been developing was that sort of that idea of insight. How much insight people have and how much substance use can basically change people's insight. So we started with this cartoon and people hated it. So we received lots of really negative response about this specific cartoon. And we changed it to this character and people liked it more. So in terms of, they have been thinking that the first one is just too stigmatized, right? And the new one is less stigmatized compared to the one in the past. And then we developed this character, people didn't like it, and then we developed a new one, but even the new one, many people didn't like it. Why? What was the feedback that they gave us when we have been showing them this new one? Matthew.
Was it more from like a race ethnicity perspective?
Race ethnicity perspective. Meanwhile, we have been running that in Oklahoma, so there was sort of Midwest sort of culture as well. But right, I mean, race is an issue, of course. What else? What else do you see here? We heard from many of our clients, this is a sort of family-based, and most of us, we really do not have that family. And the idea of family in that, it just doesn't kind of resonate well with us right now. It just doesn't feel good. So we have been asking them, okay, what would be the better character? And they really liked Wonder Woman. So we basically added that as a sort of a character to the package that we had. And meanwhile, we have been trying to develop some cartoons for people of color, okay? So we started to develop a series of cartoons with people of color, and it went really bad. So we received lots of really bad feedbacks, and people of color, they really didn't like to be in the cartoons. So at least in the pilot kind of discussion and focus group discussion that we had. So that was an area that we decided not to follow, and it realized that there are lots of nuances for that we need to consider in the future kind of studies that we are working. So there are lots of kind of interesting things that we need to consider. And meanwhile, we also started to develop animations out of those cartoons. And I mean, the next presentation will discuss about some of those animations, but trying to even animate those characters that we had and trying to optimize them based on what we have and what we need in the package. So we registered the trial, the details about the trial is already available, and we call it BrainGym 2.0. I already have the entire package here. So those who are interested to take a look inside, that is the entire package. And each session of the package is designed to be basically, so there are booklets. And each session is designed as an independent booklet, okay? That has cartoons, games inside, and also some homework. So I will show you the sort of model that we have. To be able to make it happen, we develop a sort of a model to be able to communicate with our patients about, okay, when you go and want to eat, there are triggers in the environment. And then they grab your attention, discussing about the importance of attention as an important function. You have memories about different things. When you see something that has a specific saliency or motivational valence with it. And then there is a saliency processing in your brain. You start to do appraisal about whether you want to do it or not. And then you have interoceptive experiences. We have been discussing that as a sort of bodily expressions and bodily feelings. And then you try to exert your control. And also then you have motor response and you try to. So discussing that in a sort of the context of starting with eating as a behavior, and then moving that towards substance use and trying to extend the idea towards substance use. And we had a fantastic team of colleagues there. Tara, who's here, Martin Paulus, Robin Operly, who's not here. I mean, the group, a fantastic group of people. Naeem, who is our cartoonist. I mean, other people from peer group counselors, most of our graphics. So a fantastic group of people, we call it neurocognitive empowerment for addiction treatment. As I told you, initially we started with 16 sessions, we ended up to wrap it up into 14 sessions, and the design was just organized to be step by step. So introduction for session 1, then discussing about sustained attention, then adding working memory to sustain attention, and then adding kind of flexible attention, discussing about that. So based on those levels, just adding different cognitive functions to that, and then having review sessions and moving forward and extending the entire package and having a specific guideline. This is the kind of the sort of the structure of the package. And we also added a brain planner as a part of the package that they had to basically track their daily activities and their functions in that sort of daily planner. And we also fully manualized the entire package. So we wrote every single thing that are supposed to be discussed in each session, kind of making sure that those who are running the session, they have the high level of fidelity to the entire package. And all those things are available as a part of the package. So we started the initial trial, and we recruited 1 control group, 2 active group. In each group we had something like 20 to 30 people. And then pandemic started, and we have not been able to go beyond the kind of the initial trial. But I will show you some of the initial results, and we are already working. We did kind of neuroimaging assessment of those people, and we have a 12 months follow up on that trial. So few initial kind of results that we have, giving you an idea about how was the kind of the feedback that we had. So we have been assessing kind of their feedback about different cartoons from session 1 to session 14 in terms of how much those cartoons do they make sense. On average, if you can see here, in terms of the clarity of idea, usefulness, I mean, the scores are around something like a 4, very to extremely. So that is the kind of the response to the cartoon in terms of the fitness, motivational aspect of the cartoons, the material that we had. And also, nobody was just very concerned about the offensiveness, because we have been a little bit concerned that some of this cartoon might be offensive for some people or distracting for people. So overall, the feedback was good. I mean, people have been thinking, these are the feedbacks that people provided. It was colorful, helpful, cute, memorable, enjoyable. So people perceived that as something doable and engaging in the community. And we also had a specific, what we called credibility expectancy questionnaire that we used to assess the therapy manuals and therapy packages. And as an example, we have been asking about how logical does the intervention offer to see, I mean, how do you see as a logical intervention? And they have been reporting initially in the kind of, in the initial phase of training, they had a higher sort of expectation. Over the time, as you can see here, something like 52% of very, I mean, just having high level of expectation was a little bit lower in the last session, something like 38%. But overall, they have been perceiving that as a reasonable package and successfully in terms of reducing their symptoms. So their personal assessment about the package was reasonable. And we are pushing that forward. Right now, we are applying for a larger grant to run a kind of a larger trial based on the pilot results that we already have, and trying to push that forward. Hopefully there will be a NIDA in the future, in the next few months, and we can apply for that grant if everything goes well. And that is the next step. But meanwhile, we started to put together some materials that people can use. So we developed a web page. If you search for brain recovery in addiction, you can find the materials that we put online. So we call it BARI. The website is already on, and we put all the posters, the material that we developed as sort of posters there online, and they are already available. So I already have some of those materials here for you, those who want to have a copy. And I'm happy that people around the world have started to translate them in different centers. So now we have them in 22 different languages. So during the last couple of years, people around the world started to translate them to different languages, and they're available in multiple different languages right now. During the COVID, we added a COVID sort of supplement to that, to have a COVID addition to consider different aspects of, when we have to discuss about attention and kind of what are the things that they can do to manage attention during the COVID situation. Okay, so the last slide. What we have learned from the Brain Gym 2.0 or the NEAT trial that we had. So we realized that if we do a good goal setting with the patient, communicating about brain and recovery and increasing their motivation, that is definitely an important part of the intervention. We developed the graded exercises to start from really simple exercises, and over the time we increased the complexity of the exercises, and people realized how better they are functioning in doing those exercises over the time, and also the homeworks that we have been providing for them to get them engaged. The review sessions that we had those sessions were really helpful in that process. So, and we developed kind of planner, educational books, flashcards, posters. So those materials, they have been working together as the entire package. Even we had kind of those posters mounted on different parts of the treatment center. So everyone was involved in that sort of brainy discussion about recovery. And because we have been doing neuropsych assessment for all the patients in the initial phase, and then every 2 weeks we have been continuing the neuropsych assessment, people have been very interested to know about their function. And the communication of neuropsych function with patients was a little bit tricky in terms of, because we had patients that have really low level of cognitive functions. And to be able to communicate that with them and discussing about how those things are important. So they have been very interested to know, and meanwhile how that is going to be constructive as a part of the intervention was a sort of an interesting learning lesson for us. Trying to develop what we call metacognitive awareness for those patients, and also trying to help them to use whatever we are discussing in the kind of neuroscience discussion that we have, to transfer them to their daily lives. In terms of, okay, if we are learning how to control our flexible attention, how does it mean in the daily life? How can you actually use that specific function in your daily life and in your recovery process? So having a sort of a level of transfer to daily life, and then being able to train trainers to run these sort of sessions, and having that sort of manual, and also having whatever we are doing as a continuum of the care, and being able to do follow-up for the patient, and integrating the idea of brain health and brain recovery into their lifestyle in long term. But the bottom line message was, whatever we have been doing about brain and brain games in the recovery process was engaging, and people have been interested. And we realized that we need to extend that and think how we can go to the next level. But one feedback we had was, we had a very high level of kind of commitment from the treatment centers that we have been working with. But we received feedbacks, 14 sessions is just too long, right? So there are many centers around the world that is just too much to do 14 sessions as a part of their treatment. And we had people in the treatment center for 3 months to be able to do something like 2 months of intervention. So huge level of commitment. And we started to think about, okay, how we can have smaller packages. And Tara is going to discuss about those smaller packages and how we have been able to develop them, and also going to how we are going to use them, the idea in the prevention part. Because one of the other feedbacks that we have been receiving from those moms who have been attending our sessions was just, can I have a copy of this package for my daughter who is 14 years old? Because I wish I knew all those things that you are teaching us when I was 12 years old, when I was 14 years old. Because all those skills and brain training and attention training and emotion regulation, those things, I wish I was able to use them when I was younger. And then we started to develop the idea of prevention that Jasmine is going to discuss with us. Okay, so we are going to keep questions to the end, and we hope we will have time, because those talks are going to be connected to each other. And at the end, hopefully we'll be able to further discuss. And we are looking forward to have some of you who are sitting here as our colleagues in the future to be able to run, because we are planning to run some new trials, and we are looking for collaborators and other centers and other treatment programs around the world are interested to be a part of this. And I hope that we will be able to bring you to that sort of team of colleagues that we have. Thank you very much.